So let me put this to record. So, yeah, today we'll finish reproductive. We're in a good place to finish it. And then on Monday, take that time to study. I know you guys have lab exams. My lab is Monday, so they want the extra time, and a majority of you are in this class, so it works out. And then Wednesday, lecture exam next week from today. Be prepared and be preparing for your final. Our final was set for, I can't remember, 29th. Let me check. It's posted on Blackboard, but I took a screenshot somewhere. Somewhere in here. Is this it? Yes. No, the first. Yeah, our final exam is Wednesday, May 1st, 9:30 to 11:30. Okay? So a week from your fourth lecture exam. So you guys got the better end. Academic Affairs makes the schedule. So since we're a Monday, Wednesday class, we're either Monday or Wednesday, and you guys lucked out and got the Wednesday. All right. It's gonna be 100 questions, 70 multiple choice, 30 short answer. All right. Everything from day one. Don't think something isn't important. Same thing with your final exam and lab. Don't think something's minuscule. It's not that important. Go through everything. Any section you were weaker on, spend a little extra time on it. Realistically, exam 4, I wouldn't spend much time on it unless you don't do well on it. And I'll get those graded ASAP for you guys so you know where you stand, for studying purposes, okay? So that'll be my goal for y'all, all right? All right, so let's continue on with reproductive. So endometriosis, you guys have heard of this. Some of you may even have it. What happens is endometrial glands. So if you remember, you talk about the uterus, and we have the endometrium, which is, there's the functionalis and the basalis. The endometrium is what sheds. The functionalis layer is what sheds. Well, those glands in there are what are responding to hormones. They're responding to estrogen and progesterone. And what happens in some women, sometimes during embryology, during the formation of that fetus, cells kind of land in the wrong spot, or cells' genetic information is active where it shouldn't be. And that's exactly what's happening here. Endometrial tissue is just in the wrong place. I've heard of it all the way up in the thorax on the diaphragm. It just depends. The problem with that is it responds just like it does in the uterus to progesterone and estrogen, and it enlarges, it engorges, and then it wants to shed. And so it causes a lot of pain because there's sensory in those areas, there's nerves. And so treatment typically is hormone replacement. Instead of doing this every month with your hormones, we just bring you up to a baseline and hold you there. And that tends to get rid of it. They can remove or scrape off the tissue depending on where it's at. For some women, they have endometriosis in the myometrium, and that's really painful. And so typically after they deliver a child, have as many children as they want, they opt to have a partial hysterectomy. A partial hysterectomy is only removal of the uterus. That's what we prefer to do. Reason being, we don't want to take out the ovaries because so then you lose estrogen and progesterone. You go overnight into menopause. They can do hormone replacement, but why? Why do that if we don't need to? A full hysterectomy is sometimes needed, whether it be cancer or endometriosis on the ovary or PCOS. So sometimes they do that and then they just give hormone replacement, and you never go through menopause if you do that. Okay. All right. Vesicouterine pouch and rectouterine pouch. So the vesicouterine pouch is on the front side between the uterus and the bladder, and the rectouterine pouch is between rectum and uterus. This pouch is typically where abdominal ectopic pregnancies end up. So what happens is the fimbriae are supposed to grab the egg, they miss it, and it gets fertilized inside the abdomen. And then it lands in there, it implants and starts to grow. Once again, it's a medical emergency. It needs to be removed. There are cases, and I don't know if we talked about this in this class or not, but there are cases where like Doctors Without Borders, stuff like that, where they travel overseas and take care of people, provide their services. I remember there was a case where the lady was like 70 or something, and she had a 40-pound mass inside of her, this big giant calcified mass inside of her. They imaged, well, they surgically went to remove it, and they found it was a fetus. It was an abdominal ectopic pregnancy, and the body didn't know what to do with it, so it just quarantined it by putting calcium around it. It was 40 pounds, this big, right? Mass, that she had been carrying around for like 30 something years or 40 years, something wild like that. But yeah, if you look up calcified abdominal ectopic pregnancies, you'll find them. There are cases out there. It's just crazy. Okay. Fornix, so this area is where it's kind of like the Y. I think the Y under the uterus here. That's fornix. So that's where, oh, what's the name? Nouveau ring. Pretty sure nouveau ring. Nouveau ring is a form of contraception. It's a little like rubber ring that the woman will tuck up into the fornix, and it's a drug-eluting ring, and it is a form of contraception. They change it once a month themselves. Like their doctor shows them how to do it the first time, and then after that, they do it themselves. All right. So external structures. You guys can go through this. You should have gone through it in lab. Okay. So the majora are the labia's lips, so those are the larger external structures. Minora is the smaller. Hymen. Hymen is a perforated membrane that closes off the vaginal tract. Most women rupture it when they're younger, doing gymnastics or something. That is common. Sometimes they rupture it the first time, they place a tampon or something like that, and they'll get some bleeding from it. Okay. Clitoris, we're going to run through these guys actually, right? So hold on for that. Okay. Rugae, this is for male stimulation. It's to stimulate the male so they can ejaculate. And then as far as pH goes, the vaginal pH is acidic, and that's important. There's lysozyme in there. That's important. And what this does is control microbial growth. Okay? So it's important, maintaining that flora. So women will get yeast infections if they start to alter this. What alters it? Taking baths, wearing non-breathable underwear, douching, sex, menstrual cycle, okay? Antibiotics, any of that can trigger yeast infections. Candida, which is the causation of yeast infections, is normal flora for most women. But when the other microbes get altered, the candida will bloom and you get a yeast infection, okay? We talked about fornix. All right, so we talked about hymen. Clitoris is homologous to the male penis. So when the mother is pregnant with a female, if she's exposed to testosterone, exogenous testosterone, when the daughter is born, if they're because they were exposed to testosterone, the clitoris will be too large. It'll be inappropriately sized, and they do like surgical correction that way. In other countries, this is where they do female circumcision, which is really inappropriate. It is outlawed here in the US because it is considered mutilation of the female. Okay? The structure contains corpora cavernosa, which we'll see in the male tissue, and that's what causes the enlargement of the clitoris during excitement. Okay? And then labia minora, so that's the inner, and then labia majora, that is the outer. Now on the male, these will connect and form the scrotum. So once again, if they're exposed to testosterone, these will be overly sized. All right, glands. So there are two sets of glands. The first is the periurethral glands. So these are homologous to the prostate gland, and these provide lubrication of the vagina. The Bartholin glands, these are a larger structure, and these the they're called the greater vestibular glands as well. These are active during sexual excitement or intercourse, and they allow for lubrication of the vaginal tract for the penis to enter, right? So these are going to be homologous to Cowper's glands in the male. So remember who's homologous to who, okay? These both can become obstructed in women. It happens sometimes. Sometimes you can use like a hot compress to relieve it. Sometimes they become infected. They have to be lanced open to relieve the pressure. They're incredibly painful when they become obstructed, just like the parotid gland in the mouth. Okay, it has nothing to do with cleanliness or anything like that. It just happens sometimes. Some women are more prone to it than others. Okay. As far as birth control goes, there's so many different ways. We've talked about a few. The original is OCPs or oral contraception. The downside to these is if you miss it by an hour, FSH can kick in. That's all. 1 hour. So a lot of women, when they take these, they have, like timers set up, some type of reminder, so that they can take it. So accidentally getting pregnant on these is a higher probability. Tubal ligation, this is where they cut the fallopian tube. It can be reconnected. The downside is there could be scar tissue, so there's increased risk of ectopic pregnancies, tubal ectopic pregnancies. And then there are cases where it reconnected on its own. So even though they cut the fallopian tubes and sewed them off, they can reconnect. There's been cases like that. Condoms work as long as they are used appropriately. And then IUDs, those are intrauterine devices. The original was a copper device. It's inserted into uterus, and what it does is it agitates the endometrium to where it's a non-hospitable environment for the egg to implant. So when you look at it like on birth control pills or the Depo shot or the Nuvo ring or IUDs that are drug-eluting, which is like your Myelina and Kylina, those situations the woman does not ovulate because we're giving estrogen and progesterone or just progesterone. It stops FSH release, so there is no ovulation. Tubal ligation, they still ovulate, but the egg can't make it anywhere. The copper IUD, they still ovulate, but the egg can't implant, theoretically. Okay, there is a small risk factor, and that's why Myelina, Kylina are typically better options. Cervical cap, diaphragm, this is really old. I don't even know that anyone uses this anymore. Basically, what they would do is in the fornix, they would place a plug. It's also referred to as like a rubber dam. And so it stops the semen from getting there. There's also spermicides, a sponge that can be put in there with spermicides. But those are typically older options. You really don't see those used anymore because the effectiveness is much lower. Okay. So the woman would have to place it right before intercourse, typically. Okay. Progesterone patch, so this is like Depo shot, that's what they're talking about. It stops FSH, and so we do not see the stimulation of the primordial follicles. Okay? In other countries, they have started doing birth control for males. Okay? Where same concept, that they can stop the release of or the creation of sperm, and that's what they're targeting. Okay. In males, so typically when people come in and they're like, I can't get pregnant, a couple comes in, it's typically the male. It's usually not the female. If the female is having a normal menstrual cycle, it's not her. You can almost bet on it, unless there's something anatomically wrong. Okay. Like she has tubal ligation, right? You're gonna have some trouble there. But typically it's the male, or it is intercourse habits, which is kind of wild. Uh, Especially when you go into cultures where people don't talk about sex. Like here in the US, it's not taboo. We talk about it, we educate people in school, stuff like that. In other countries, it's very taboo. You don't talk about it. You live with mama and papa until you get married, and then you go figure it out. That's how a lot of other countries are. Um, so people will have, I've literally heard stories of this. They have sex during the woman's period because that's when they think she can get pregnant. I've even heard a story where the couple were just lying next to each other and thought that's how they would get pregnant. They took it biblical. Okay. Yeah, be surprised. Male habits have an effect on their sperm. So we're going to talk about that in a minute, but temperature. If a male takes hot baths or sits in a spa every day, it will actually kill the sperm completely. There was a study done on it where they were having males dip their scrotum into like hot water, not like burn yourself hot, but just hot water for 30 minutes a day, and they were sterile temporarily until they stopped that. All right. So, as far as the testes go, that's where we're going to produce sperm. They actually develop in the abdomen and then they descend down. And as they descend down, they pull with them ductus deferens or vas deferens. That's what carries the sperm from the testicles. Blood vessels, vein, artery, lymphatics, and then nerves. Along with it descending, there's going to be a couple layers in here. The cremaster muscle. So we'll see that is what's going to elevate or descend the testes. And that is to control temperature. Because like I was just saying, temperature can have an effect on the sperm and can actually kill the sperm. So the testicles are actually external to the male body. And then tunica vaginalis, that's just peritoneum over there. Cryptorchidism, this is where a testes or both testes do not descend. They'll give them a couple months to allow it to descend. I want to say it's 6 months. It's decently common. You see it quite often. If it does not descend after a certain amount of time, it actually has to be removed. What happens is the male will be infertile and have very high risk of testicular cancer. So what they'll do is remove the undescended one, and then they'll put in a prosthetic. So the male will look normal, will function normal. No one's the wiser. All right. Temperature control. So really the cremaster plays the bigger role in here. We have to control it. It has to be below body temperature. If it gets too high, the sperm will die. So underwear choice also can play a role in here, depending on what the male is wearing, right? The dartos muscle, that also causes wrinkling of the scrotum. So really he plays a slight role in temperature control, but the cremaster plays a bigger role. All right, so cremaster, if it's cold, the cremaster will contract and draw up the testicles. If it is hot, the cremaster will relax and lower the testicles. I did not make these slides. Do not judge me. I need to just go delete that nonsense. All right, spermatic cord. So you need to know what's in the cord, and we've listed them, right? Because everything descended with the testicles. So the cremaster muscle for elevation and descent of the testicles. The artery, the vein, the lymphatics, the nerves, ductus deferens or vas deferens. Okay. I can't remember if we talk about torsion in here. Do they have torsion in your notes? Testicular torsion? Okay. It's in here somewhere. I always get confused because I cover in Path Phys. We cover a lot of this stuff, like the disease states. So I forget like if we talk about it in lecture or not. All right, tunica vaginalis, that's the peritoneum, okay, the outside covering. And then albuginia is the fibrous tissue. It's divided into lobules. The lobules contain the seminiferous tubes or tubules that you guys learned about in lab. That's where sperm or spermiogenesis happens at, okay? So the meiosis of the male. We talked about this. So no need to go over this. We talked about this, okay? We looked at the same exact slide. We talked about the Sertoli cells. I don't know if we mentioned the blood testes barrier. Just like in the female, the follicular cells create a barrier to protect the egg. The Sertoli cells, their connection between each other helps protect the sperm because the DNA is foreign. If there is too much sperm, or sorry, yeah, if there's too much sperm, then they release inhibin to stop FSH. Okay. And then they also have what is called androgen binding protein, so they can bind the testosterone to use for nourishment of sperm for their formation. So they also call them nurse cells, is the other name, because they're nursing them through their growth. Leydig or interstitial cells, so remember those are outside of the seminiferous tubules. Those are going to produce the testosterone. They don't stop, all right? Then the male makes them from beginning of puberty to death, or makes testosterone from beginning of puberty to death. The levels are different. When you talk about a male going through puberty, the levels are very high. Hence the leaning out, the muscle growth, all of that. And you get to middle age, it kind of tapers down a little bit and a little bit lower, but it's still producing. So as like males age, you'll see muscle mass decreases. Um, there's nothing you can take out there that will affect testosterone levels outside of taking testosterone. I'm sure you guys have seen those commercials, Testofen, and they have like that former football player trying to push this like product that like will boost your testosterone levels. Gimmick. All right. Something you can like follow in life is if a pharmaceutical company has not patented it and is trying to sell it or sell it as a prescription drug, it's pretty much useless. That you can take that to the bank. Okay. That means it doesn't work. They can't patent it for like its effects. Waste of money. All right. Over the counter drugs, they probably were patented at one point, or they are so safe, like Tylenol, aspirin, stuff like that. It's so safe that the public can have open access to it. Um, and things are changing with that. Like uh, certain contraceptions, for example, for women are becoming easier to prescribe. Like now, like certain states, I don't know if Georgia's one, pharmacists can just give you contraception. You just go like up to the pharmacy and they can dispense contraception to you without a prescription. Little sketchy because if the female has a history of like smoking or blood clots and someone doesn't really verify that, they're going to be at risk of throwing another clot. So like, not the most ideal drug to be doing that with, but at the same time, it's pretty darn safe. Okay. So just a reminder here, FSH stimulates sperm. So if sperm levels are low, FSH should be high. If sperm levels are high, FSH should be low. Same thing with testosterone and LH. If testosterone levels are high, LH is low. If LH is high, testosterone should be increasing. So what does testosterone do? Male hair pattern. So the placement of male hair, a beard, stuff like that. So when women have exogenous testosterone or like PCOS because they start creating more testosterone, they'll start, like a mustache, stuff like that. Enlargement of genitalia for the male, the thyroid cartilage. So this is why males have deeper voices. So it stretches your vocal cords, longer vocal cord, more like bass tone. And then protein anabolism. So that's why males can have leaner or more muscle mass. And that's why, like, my wife wants to shoot me right now because since January, I've dropped 7 pounds. And I think in a year, she's dropped 8. She is not happy. Okay. It just, I have more testosterone. I hope I have more testosterone than my wife. We're going to have another discussion, right? um, but because I have more muscle mass, I diet for a little bit, I'm gonna lose more. That's just natural. Always with males. You always hear about that. The male just thinks about dieting and loses 10 pounds, where, female's been dieting for ages and calorie counting and everything and loses like half a pound. Okay. That's normal. Epididymis, this is where the seminiferous tubules connect to in the end. This is where sperm will mature. It is ciliated and it helps move the sperm along. Now, for the male, they can undergo a vasectomy. A vasectomy is cutting vas deferens. All right? Pretty easy procedure. If they do that, they still generate sperm, they still generate testosterone. It just can't make it out. Just like tubal ligation, it can't make it out. And so what happens is it's just reabsorbed inside the epididymis. So ductus deferens or vas deferens, when you guys are looking at the cat, remember that's what loops over the ureter. That's how you find it. You follow the ureter down and then looping over ductus deferens. It'll move, or sorry, it has smooth muscle, and so what happens? It'll move the sperm through peristalsis. Okay, it's coming up through the inguinal canal, so it's just a passageway through there, through where the testes descended through. It's inside the spermatic cord, right? And where it's going to enter is right before the prostate. When it's doing that, it's going to combine or form a union with the seminal vesicle. So what we'll see is what's coming out of the ductus deferens really is just sperm. The rest of semen is coming from seminal gland, prostate gland, bulbourethral glands. So in reality, when a man gets a vasectomy, no noticeable difference. They still would ejaculate like normal, volume would look normal, no noticeable difference. Okay? So pathway of sperm, you guys can go through this, but it's just from when we generate it, and then as it's passing all the way through, and then once it's ejaculated, how it goes through the urethra. So the prostatic urethra, membranous urethra, penile urethra. So same thing here. Okay. Just another, now they have the visual. So accessory sex glands, seminal, prostate, and then calipers or bulbourethral, one and the same. So seminal vesicle. This is the first to join with the ductus deferens, or who joins with the ductus deferens, and creates what's called the ejaculatory duct. Now, semen is made up of many components. One is sperm, right? So 60 to 65% of semen is coming from the seminal vesicles. What do we have in here? Mucus secretion. We're going to see it's alkaline because of this. That's to protect it because we're going to pass through where urine was. Urine is acidic and would destroy the sperm. Fructose, citrate, that's for energy. The sperm needs to be able to swim. Remember, they have a lot of mitochondria. Fibrinogen, it's a clotting protein. So what happens is the sperm will clot up to protect it from the female secretions. And then prostaglandins. These are actually to stimulate the female vaginal tract and uterus to potentially contract so that it can move the sperm up into the fallopian tubes. Prostate gland, 20 to 30% of the semen. So if you think about it, we're now at, on the high end, 65%, on the low end, wait, what did I say? 65? No, 95%. On the low end, 80%? Yeah, 80% total volume of ejaculate between these two glands, okay? Here we'll see more citrate, buffers for acidity, seminal plasmum, which is an antibiotic to help protect it, and then fibrinolysin, a lysing factor, so that that clotted semen eventually can break down and be released once it's in a safe area. What they're showing here is DRE, or digital rectal exam. It is the only true way to check a male for prostate cancer. It's also how they'll measure like BPH, benign prostate hyperplasia, even though it's a hypertrophy, an enlargement of the prostate, which is benign. Okay? So at age 45 now, males need to go get prostate exams to verify or check for cancer. Okay? It's preventative medicine. It used to be 50, they moved it down. They're getting more aggressive because that means they're seeing enough cases early on that they should be checking. Yeah. I had a buddy, God rest his soul, he passed away a few years ago. He had a very poor sense of humor, and he was getting up to that age. And he's like, he calls me up one day. It's just horrible sense of humor. He's like, Peter, I started doctor shopping. I was like, why are you doctor shopping? You don't like your doctor? He's like, nah, his hands are too big. I was like, I gotta go, Jeff. Just, I need better friends. All right, bulbourethral or Cowper's gland. This generates, we'll call it another 5%. So if you think about it, we're almost at 99%, we'll call it, potentially, of total ejaculate. In here, there'll be, they call it like pre-ejaculate, and what it's doing is neutralizing the acidity of the urethra so that to protect the sperm. Now, there can be sperm in here. This is always like that misconception that people want to practice, like the pull-out method. There can be sperm, and the female can get pregnant. Right? As far as semen goes, 100 to 400 million sperm per ml, and there are 2 to 5 mLs. So, I mean, you could be talking what? Close to 2 billion sperm per ejaculation. That's crazy when you think about the females releasing how many eggs? One. Wild. Okay? So the ability to fertilize the egg, very high probability. Emission and ejaculation. Okay. So what's happening here is as the male is aroused, they start to move the sperm into the ejaculatory duct. And what's happening is it's mixing everything we were just talking about. When ejaculation happens, there is smooth muscle contraction and the sperm is expelled through the urethra. Okay, so it's already gone through the prostatic urethra and now it's going to go through the membranous and penile urethra. And a horrible memory tool with that is point and shoot. Point is for erection, it's parasympathetic. Shoot is for ejaculation, it's sympathetic. That's how you remember that. Okay? It's the point and shoot. Vasectomy. So what happens is they give you some anti-anxiety medicine, a local anesthetic, cut the scrotum, cut the vas deferens, suture it. That's the end of it. It's like a 15-minute procedure. Very non-invasive, done outpatient. The male just needs to ejaculate a couple times, and then it is safe to practice sex without fear of getting a woman pregnant. Okay? Does not take much. Versus tubal ligation, I mean, they got to cut you, go through all the abdomen. It's a big old process. So some women will, if they're having like a C-section, they'll opt to do that because it's already all open and everything. But a vasectomy, very non-invasive, very quick. Okay? A buddy of mine, he was my best man at my wedding. He had a vasectomy done. He went to his brother's clinic. His brother is his younger brother is a urologist. I had to give him a hard time for that. He swears up and down his brother didn't do his vasectomy. I was like, I don't know. I don't know. All right. But yeah, it's common. Males do it. It is reversible. It's actually safer to reverse a vasectomy than it is a tubal ligation. Like there's a chance you can't reverse a vasectomy, small chance, but the same thing with tubal ligation, small chance. But the risk factors are much higher with tubal ligation. One, it's a true surgery. Two, you now have scar tissue in there, so you can get up with end up with an ectopic pregnancy. So vasectomy, easier to reverse. I remember in Florida there was like this one surgeon, he had billboards everywhere advertising for vasectomies, and I think he charged like $200 to do it or something crazy like that. Wild. They have billboards everywhere now with divorces cost $99 in Florida. So my brother-in-law, we always joke and we're like, do you me send you $99? It's our running joke. We're gonna raise $99 between the two of us. All right. Um, so as far as the male penile tissue goes, we have three sections or three compartments. Corpus spongiosum. So this is right next to the urethra. The urethra is passing through here. And corpora cavernosa. Cavernosa is what's going to fill with blood and cause erection. All do not contain erectile tissue. If they did, it would compress the urethra and the ejaculate could not exit. Okay, so only corpora cavernosa has erectile tissue. So corpora cavernosa, and then there's spongiosum. That's the urethra in the middle. By the way, his younger brother is the one that the 16-year-old with they were cathing each other. And that was him that dealt with that. He had another great story. So the other great story is you can tear this tissue if people are not careful. And he had a case where a couple were having sex and someone got a little overly excited and they bent the penile tissue when it's erect. You tear corpora cavernosa. And so once that happens, it creates scar tissue and then creates Peyronie's disease or Peyronie's disease, which they were advertising on TV recently too. Some males are naturally born with too much curvature, and so they have trouble with intercourse, depending on the curvature. And then situations like this. So what they typically need to do, because it also can affect their ability to get an erection, they do penile implants at that point. They have to correct the tissue surgically, and they'll put a penile implant. And then what happens is the male actually has to insert a device into it and inflate it before intercourse. So be careful. All right, prostatic urethra. So that's where it's traveling through the prostate. Transitional epithelium, because we're just coming off the bladder. Membranous urethra. So this is pseudostratified epithelium. We're transitioning. So this is going through the pelvic cavity. And then penile urethra, also pseudostratified. This is going through the remainder or external penis. So you can see there's prostatic, and then we have our membranous, and then we have the remaining penile urethra through there. So we talked about this. Erection parasympathetic, so that's the point. Nitric oxide is what's controlling this. So when they created Viagra, because that's what it does, it causes an increased release of nitric oxide. It was an accidental side effect discovery that it would cause erections. Originally, it was for pulmonary hypertension. The root or true use of that drug is for pulmonary hypertension. Vasodilation in the lungs reduces stress on the heart. So sildenafil is the true name of the drug. And then when they figured that out, they created Viagra. Viagra is extremely expensive, and they only dispense, I think it's like 6 pills a month. That's all you can get. And it's something like $100 a pill, technically, some astronomical number. Right? So when the arterioles dilate, then blood enters, it compresses the veins, and the erection is formed. When they constrict, the veins slowly release the blood, and the erection goes away. So blood is not actively circulating through there. And the reason I bring this up is people with like I just blanked. Why did I just blank? Their blood goes into crescent shape. Sickle cell. There we go. Sickle cell disease. My wife had a patient a few years back where this happened. He came in with an erection, and it's because all the cells sickled and blocked it, and so the blood couldn't leave, and so they had to do a couple of like injections to reduce it. They gave him vasoconstrictors, and it wouldn't. It had been several hours at that point, and so the tissue can become necrotic. So they actually had to put him under and do a couple hundred micro injections of um, these vasoconstrictors to reduce it to save the tissue. So you see that happen with sickle cell disease. And then you see with like, diabetes, it affects the ability and high blood pressure, it's smoking, it affects the ability for the male to form an erection, which is really good information, for patients because sometimes they don't want to take meds. They don't want to stop doing, smoking, stuff like that. I remember we had some guy come in, his A1C was 14 point something. And my preceptor is talking to him, and this guy's, I don't need anything. I'm great. I don't have diabetes. Just denial, straight denial. And then my preceptor's talking to him, and he's talking about how he's going to go on some trip with some woman and, all this. And my preceptor just straight up told him, he's like, I mean, that's great for you, but nothing down there is going to work for you because of this, and explained it to him. And the guy's like, let me get that metformin. He was ready to start taking medication. And sometimes, educating the patient about stuff like that. Gotta do what you gotta do. All right. So, what causes impotence, which is the inability to get an erection, um, damage to the sacral spinal cord, damage to the blood vessels, like we just mentioned. So, anything like that can lead to it. And then a majority of impotence is psychological. It's actually the male. They typically talk about its performance anxiety. And so it's in their heads that they can't perform, and so they will develop impotence. And a great example of that, preceptor told me, patient came in, same preceptor. A patient came in, and he told him he can get an erection with his girlfriend, but can't get an erection with his wife, and wanted Viagra. My preceptor sent him on his merry way and said, "You need to go talk to a therapist, is what you need." People are wild. All right. So during intercourse, for the male, lubrication phase, that's that CalPERS or the pre-ejaculate. Parasympathetic, member point, that's the erection. And then sympathetic shoot is the ejaculation. Because that sympathetic comes online, you see in the male, sympathetic response throughout. So the increased blood pressure, heart rate, all of that happening. Circumcision. So on the male, we typically produce or not produce. We typically do circumcision like day of birth, day after, and so what they remove is the foreskin. A lot of people do it for religious reasons, but hygiene reasons and prevention of cancer are really important reasons to do it. The foreskin will trap bacteria and debris under it. The male has to be trained to retract it and clean it, all of that. Otherwise, it actually can inflame to the point where they cannot retract it and they have to get a circumcision as an adult. Extremely painful at that point. It's quick. The neural network of the baby is not formed. I've attended circumcisions. They don't even use a local. It's kind of like ear piercing, like you pierce the kid's ear and like within minutes they're done. They forget that it happened. Um, the pain is gone. It's the same thing. They just retract or they pull it up, they pinch it, clip it, done. The baby cried. Every single one I attended, the baby cried for maybe 30 seconds. That was it. Done. Okay? Done. Done. All right. Do you guys have anything you want me to go over since we're done so early? We actually finished real early. Anything you want me to go over? We got time. Oh, so we didn't talk about torsion. Little blurb. So torsion is where the testicle will rotate on itself, and when it does that, it twists the artery and chokes it. The testicle will die within hours. So I think it's like a 3 or 4 hour window where they must elevate it. That's the procedure they do. They elevate it and it will unwind itself. If not, they do surgically need to correct it or it will die. And then it has to be removed. And then there's also what else? I'm blanking on the name again. What is up with me? I'm just tired. I've been doing yard work. So I was planting hydrangeas yesterday, and so I'm digging holes for them, and I broke 2 shovels. That's what I'm dealing with. Just snapped the shovels in half. I was like, I quit. We're done today. Um, Hernias. There we go. Hernias. The males can develop hernias, so that's why, like when for sports, whenever someone wants to play sports, male or female must go for a physical every year. Why? We listen to their heart to listen for murmurs because they can have defects and not know about it. And then for the males, we check the testicles for hernias. So they'll herniate abdominal contents down into there, or the veins will become similar like hemorrhoids down into there. And both will need surgical correction. And there's one also where the baby, it's typically in babies, they get fluid in it. The scrotum will fill with fluid. You can shine a light on it and it'll just shine right through. And that one usually corrects itself. But any hernia for the male into the scrotal sac will cause sterility if it's not dealt with because of the increased temperature. Pretty interesting. Anyone at home have questions? You guys are just ready for your test? Just ready. Okay, we got some questions. Okay.
The spinal cord is involved in this reflex. They're talking about erection.
So the reflex for erection is sacral. That's the part of the spinal cord that controls that. So in patients that have um, certain lesions of the spinal cord high up enough, they won't get erections. They can't. Or they can actually get spontaneous erections for no reason because of the reflex uh, cycle where there's no communication from the brain. They could just get spontaneous erections.
Like random.
Yeah. And then Leslie, yeah, no class on Monday. By the way, speaking of impotence, another diagnostic factor for impotence is they ask the male, do you get an erection when you wake up? Like, do you have an erection when you wake up? So night somnolence, turbulence, forget the proper name. That is an identifier that the system is functioning normally. In their sleep, it is normal for a male to get an erection because of point and shoot. Point is parasympathetic. What do we do when we're sleeping? What system is active? Parasympathetic. Okay? So that's a sign that everything is functioning normal. What other questions you got?
In males, orgasm occurs during.
I think they're looking for emission or sympathetic. Yeah, the male orgasm occurs during, should be emission.
Instead of ejaculation.
Ejac should, yeah, right? I'm not losing my mind. Am I swapping it? Ejaculation. Because emission is when it's starting to, technically they're separate. Emission is when the sperm is starting to come out, but ejaculation is when it's exiting the body. They go hand in hand. Because if it makes it during emission, we say it goes all the way to the prostatic urethra. If the male stopped at that point and urinated, then semen would start coming out with it, and that doesn't happen. They go hand in hand. Yeah.
But because erection is mediated by the neurotransmitter nitric oxide.
Yeah, nitric oxide for the neurotransmitter, which, yeah, yeah. Any others? No one at home? No questions?
Do primary follicles contain secondary oocytes?
No, primary should be primary oocyte.
Or sorry, primordial.
Primordial, yeah, primordial definitely primary. I don't know if that was in here. Was that in here? We talked about that? Yeah. Yeah, secondary oocyte is during primary follicle. Primordials have primary oocyte. Yeah. Once we do that first split and we form the first polar body, then it is the secondary oocyte, which is in the primary follicle.
Oh, and then it goes to secondary.
Oocyte in primary follicle. Yeah.
Is the mature follicle the tertiary?
The mature follicle, yeah, tertiary or Graphian. Yeah. Any others? Any more questions, Madeline, or
No.
tapped out? Okay. Guess we'll call it there. Remember, guys, do your evals. They're probably going to come out next week. I haven't gotten alerts yet. Do your evals on Blackboard. They're anonymous. They even go through it and check, like, to make sure no one, like, put something in there that can identify them. And then we don't receive them till after grades anyways. So please fill them out. It's